Eventually, even the serum immunoglobulin levels, which are basically indicative of your B cell activity, so they would also start falling. It's easy to understand how that would happen. You can take a moment to reflect on how T cell activity affects B cell activity. So because the target of HIV is the CD4 helper T cell, it is automatically going to uh, interfere with the second signal that the B cell gets, the CD40-40 ligand interaction, which is important for B cell activation into plasma cells, for isotype or class switching in order to change IgM into IgG, A, and E. So, as is mentioned here, that the serum immunoglobulins, especially IgG and IgA, so those would be decreased, and that is the reason why you will also find, see, IgG is the long-standing antibody for any particular infection. The early infection is always IgM, but the secondary infection or uh, long time after the primary infection, you will only find IgG. So IgM is produced at the time of infection, but gradually that IgM changes to IgG. The same happens in hepatitis. For example, let's take the example of chronic hepatitis B. Okay, so if the patient is IgM antibody positive, that means the infection has happened just now. It's an acute hepatitis B infection. Whereas at a later stage, it becomes IgG. So if you find IgM negative but IgG positive and hepatitis B surface antigen positive, that means the patient is infected. He is HBV positive, but he was infected in the past. So always IgM changes to IgG in the future. So, but here what will happen is that even the IgG will go down. So if you remember that graph of the stages of HIV, automatically in the later terminal stage AIDS, the antibody response also falls. So here, the antibody which was positive so far, it was negative in the initial window period, but later on it has been positive throughout, and it has played a role in decreasing the viral load during your asymptomatic phase. But now, towards very near the patient's death, actually, even the antibody response fails the patient. So now the patient is left with neither T cells nor antibodies to fight the infection. So your viral load will keep on rising continuously until the patient is finally finished. Okay. And then impaired cancer immunosurveillance. So again, take a moment to recollect which T cells help in cancer immunosurveillance. Is it the CD4 or the CD8? So it is the CD8 cytotoxic T lymphocytes, right? So CD8 cells, they attack intracellular pathogens being presented by the non-professional antigen presenting cells. They are not, or other non-antigen presenting cells. So they recognize altered self cells, if you remember. Altered self cells meaning cells which have been infected by the virus. So some cells which has been, like for example, the HIV virus. So HIV virus has infected some T cell. So that T cell is now T cell or the macrophage or the monocyte having the integrated pro-virus and producing the viral particles. Those viral particles will be processed by the which pathway of antigen presentation? The cytosolic pathway. And it will be presented along with the MHC1. So all cytosolic proteins or all endogenous ligands for T cells are processed through the cytosolic pathway and presented with MHC1, including cancer. So the two classical examples that I had mentioned about altered cells, one was the virus infected cell, one was the cancer cell. So in both these examples, the proteins which are produced, translated by the ribosomes, are finally brought into the endoplasmic reticulum, complexed with the MHC1 and expressed on the surface of that particular cell, that particular altered cell, which will be recognized by the CD8 positive cytotoxic T cell that will come and kill. Okay, that will kill that cell because it is not cytotoxic T cell when it becomes active. What does it do? It does not secrete cytokines like the helper T cell. It kills by secreting perforins or granzymes or fragmentins. So it is going to create punch holes in the cell, or it is going to induce apoptosis of the cell. But in cases where the cancer can escape the CD8 response, so how does that happen? One example, we said that the cancer can masquerade as a self-antigen using the CTLA4 that we studied in the last class, in the class on tolerance. So that tolerance can also help the cancer survive. So in that case, we use PD-1 checkpoint inhibitors or anti-CTLA antibodies. So that is known as cancer immunotherapy. Here, that is not the mechanism. Here, what is happening is that here it is because of your CD4 cells. Okay, here that was, I mean, my point was just to revise that particular topic, but here the immunosurveillance is impacted because the CD8 cell also, like your B cells here, need CD4 helper cells. Even your CD8 cytotoxic cells need T helper cells. So just remember that T helper cells are the primary regulators of immunity in us human beings. So CD4 cells secrete those cytokines that are going to help the B cell become active, that are going to help the CD8 positive cytotoxic T lymphocyte, that are going to help other T helper cells. So if T helper cell itself gets impacted, which is the beauty or the whatever you can say, the the graveness, the seriousness of this disease of HIV/AIDS is that it is going to impact that central nodal cell of our immune system, the CD4 helper cell. So it is going to impact not only cell-mediated immunity, it is also affect the B cell or the humoral immunity, and it will also affect the cytotoxic component of the cell-mediated immunity. Okay, that is cancer immunosurveillance. So the patient will present with less often seen cancers like Kaposi sarcoma. So they will be susceptible to malignancies. So these are that's the whole big list of opportunistic infections that can happen. Candidiasis being the most common, so that is very important. You can see cervical cancer over here, so another opportunistic malignancy, you can say. The more important infection, so this is the common infections patient generally present. So this is an oral candidal infection. So this patient, it's a female, as I can make out. So she has oral thrush. Okay, vaginal thrush also is a common problem. Esophageal candidiasis also is common. The most common HIV encephalopathy, you can see that is because of the direct cytopathic effect of the virus. Another malignancy, Kaposi sarcoma. But the main cause of death generally is the Mycobacterium tuberculosis. So tuberculosis is a very common secondary infection affecting HIV positive people. Even in India, a lot of people have coexistent HIV and tuberculosis. Similarly, the second most common or very common cause of death is pneumonia or respiratory infection. So pneumocystis carinii pneumonia. Okay, tuberculosis, pneumonia, or it could be your wasting syndrome. So there could be severe wasting diarrhea because of recurrent gastrointestinal infections. You already saw that the gut associated lymphoid tissue is totally destroyed by HIV. So you are prone to several viral or bacterial and gastrointestinal infections. Those are the common, or some malignancy. Malignancies are also a common cause of death. This is oral candidiasis. So just remember, opportunistic infections are those which are not normally found in an immunocompetent host, but these organisms are able to infect an immunodeficient host. So that is why different opportunistic infections can appear depending on which limb of the immune system is affected, whether it is the innate system, the phagocytes, the complement, or it is the adaptive system, the B cell, or both T and B cells. Okay. So coming to diagnosis, so we saw the causative organism, we saw how the pathogenesis. So etiology is the cause, that was the virus. Pathogenesis is how it manifests inside the body. So entirely it is called etiopathogenesis. Now, and then we saw some clinical features. We didn't go into the details of clinical features, but flu-like symptom is the early acute phase, asymptomatic is the middle phase, and then opportunistic infections are the late phase. Now coming to diagnosis. So what will you use apart from history and examination? What can the doctor do? So doctor can ask for tests. ELISA, what is the full form of ELISA? Is enzyme-linked immunosorbent assay. Assay is nothing but quantitation. Assay means measuring the amount, quantity. So it's a quantitative, maybe qualitative in some cases, but maybe qualitative or quantitative. So in this case, it is qualitative actually. But you are measuring beyond a certain threshold, that is. So beyond a certain threshold, you're calling it positive. Okay, so just remember, in this case, it is a qualitative assay, but assay means measurement. Okay, so enzyme-linked immunosorbent assay, it is the screening tool. What do we mean by a screening tool? So screening tool is something that you apply to a larger population, to a big population, generally to an asymptomatic group of population in order to find out some disease. So screening tool is highly sensitive. That means you will learn these terms in community medicine, sensitivity and specificity. So a screening test is highly sensitive, means it is designed in such a way that it will not miss out on any cases. Okay, it might give false positives, that it might say someone is HIV positive even though he was negative, but it will never do the ghastly mistake of calling someone negative when he was actually positive. So those are screening tools. So they are highly sensitive. That means they will err on the side of positivity. So they will give false positives. Whereas a specific test, something which is specific, is will err on the negative side. So it may give false negatives, okay, but it will never give a false positive. So if a specific test says something is positive, some individual is positive for a disease, it is more likely to be true. In a screening, it is likely, but you have to confirm it. You still have to confirm it. So generally, the order is that you apply a screening test first and then a confirmation test. So first, you just uh, filter out all the people who are likely to have the disease, and then through the confirmation test, you remove those who have been tested falsely positive. So, so ELISA is the screening tool. So it detects basically it's an antibody based test. So it can detect either antigens or antibodies. Okay, it can be used both ways. You will learn this in microbiology and in pathology. But the basic principle is that, so in this case, the principle is that it is detecting the antibodies, host antibodies. So if I am the person being tested, the ELISA test will try to see if I have mounted an immune response and if I have generated antibodies against proteins of HIV1. So the P24 or the matrix, the P70, P24 or the capsid protein. So capsid is the most immunogenic of the HIV proteins, and the antibody to P24 is what is generally checked in ELISA. Appearance of antibodies in the serum takes usually 6 to 12 weeks, but may take longer. So that is what I mentioned as the window period. So that is the window period wherein the patient will have, so in that window period, the antibodies have not risen yet. So there are no antibodies. So ELISA test will come negative, but the HIV virus load is very high and the patient is highly infectious. So that is known as the window period. So at the end of that window period, the patient becomes ELISA positive, or he is also known to have undergone seroconversion. So his serum is now positive for antibodies. Before that, his serum was negative. So a seropositive person will give a positive ELISA. Finally, to confirm any patient who is testing positive on the P24 ELISA, he or she will be confirmed using the more specific Western blot test. So Western blot will detect, again, it's an Western blot is also an immunoassay. Okay, it's also an immuno diagnostic technique, but it's an immunoblotting. So in that you just use an electrophoresis. Protein electrophoresis is done how? So you already did a practical on DNA electrophoresis that was done through agarose gel electrophoresis. Proteins, we use polyacrylamide gel electrophoresis or PAGE. So first you run a PAGE in order to separate all the proteins in that mixture based on the molecular weights. And then, so this is based, so the nomenclature is based on the molecular weight. You can see here, P55, P41, P24. They are all based on the how many kilodaltons they are. Okay, how many, what is their molecular weight. So you run, you run a ladder alongside with the protein, the serum proteins obtained from the patient. You run that, and then you blot it on a nitrocellulose membrane, and on that membrane you code the different antibodies that you want to check for. So you will use antibodies against these it detects antibodies against several proteins. So then you will use an anti-antibody. So you want to check for antibodies, then you will use an anti-antibody. If you want to check for antigen or protein, then you will use an antibody. Either way, so it's an immunoassay. So you use that. So in Western blot, you are detecting several HIV proteins together. So that means you are using, it's more specific. So you are checking for P24, P41, P55, like that. We didn't discuss these. I hope they are there in the table. If you want, you can see. So what can you do for the window period? If let's say I being a doctor, I am working as an intern in a hospital and I collect the patient's blood and I do a very stupid thing. I try to put the needle back into its cap which is never to be done. Ideally, the needle has to be just thrown away. Okay, you cut the needle, burn the needle, or simply put it into a puncture-proof container. But I try to put the cap back on the needle, and in that I prick my finger. So I do that. So what can I do now? It's a window period. My ELISA obviously is going to come negative. What can I do if I really want to make sure that I haven't acquired the infection, or someone who has had unprotected sex or is anyway fearful that he wants to get tested. So the only way in which you can do the diagnosis within the window period is through an RT-PCR. So that is what is being followed for coronavirus these days. So the same thing can be used for HIV. So HIV RNA can be detected. So you have the single stranded mRNA. This you will find only in the actively replicating virus. So that is why I said that even your row virus will be difficult if no actively replicating virus is present. In fact, in the asymptomatic phase, many times the viral load falls very low. It doesn't mean that provirus is not there. Provirus is there, but it is not active. So when it is active, it will give the mRNA, single stranded RNA. And that RNA can be reverse transcribed, first strand synthesis, second strand synthesis, that will give you a double stranded DNA. And then you can do your whatever. So that this is the site of primer attachment. So you will get products this size, this size and this size. So that products you will get, and you can do that. And this nested PCR primer, that means within that product you can further add different primers and do some nested sequencing. So that also can be done. So like I said, it is used for specific diagnosis within the window period, for example. It is also used for assessing the viral load during treatment. So during treatment, if you want to check whether the viral load is falling or rising, you can do an RT-PCR. So without treatment, so now coming to, we have done the etiopathogenesis, clinical features, lab diagnosis. After lab diagnosis comes management or treatment. So without management, what happens? Most HIV patients progress to AIDS, develop opportunistic infections. First, they will develop thrush. You saw that lady's picture. Finally, they will develop more serious infections. The death is often due to tuberculosis, pneumocystis, or severe wasting diarrhea, or due to malignancies. Without treatment, like you saw on the graph, 9 to 11 years after acquiring the virus, the patient usually meets his or her end. So because the virus will keep replicating, and this is the load of CD4 cells which was there prior to infection. So once the virus keeps on replicating, your CD4 cells keeps on falling, and the patient is going to die. But if you give treatment, you can keep the virus load to a minimum. You can keep the CD4 cells high. Okay, I'm not saying you can eradicate the infection, because there will be latent reservoirs present within the latently infected CD4 cells, but you can make the lifespan longer. Okay. So treatment is directed at the various stages of the viral life cycle. So take a moment to recap the viral life cycle. Binding, fusion. So this is GP120 and CD4, and then GP41 to chemokine receptor. That will lead to fusion. Okay. So, and then fusion, the nucleocapsid will be released. Then the final single stranded RNA, the RNA DNA hybrid, and the double stranded DNA. So that is through reverse transcription. Translocation into the nucleus. Here it will integration using the integrase enzyme, and then it will undergo transcription to give rise to your, whenever the whole DNA will be replicated during cell division, the provirus will also get divided, but that is not the same as transcription. That will just be it will still stay part of the genome. But when it gets transcribed actively, it's been written as replication, but it's mainly transcription. On transcription, it will give your RNA. Either it will be a singly spliced, unspliced RNA, or a singly spliced RNA. Unspliced RNA will come as genomic RNA. Singly spliced RNA will be translated. So here translation step they haven't given to give your various proteins. They will be assembled under the host cell surface. And finally, when it buds out, it will acquire the envelope again. Here it had left the envelope. Here it will take up that envelope again. So binding, fusion, reverse transcription, integration, transcription and translation, assembly, budding. So these are the various steps where our drugs or management strategies will be, even the research strategies. Many things are still under research. So drug targets of anti-HIV therapy. So you can see here, binding receptor, at the stage of binding, chemokine receptor antagonist, you saw CCR5 antagonist. At the stage of inhibition, fusion, at the stage of fusion, so fusion inhibitors. So there are some drugs called like enfuvertide. Don't need to remember any names. So that inhibits the fusion. Then comes the reverse transcription. So there are reverse transcriptase inhibitors, which we will see in some detail. Then the DNA double stranded gets translocated and it integrates using the integrase enzyme with our genomic DNA. So there are integrase inhibitors. An example being raltegravir. Okay. Then again, please don't remember the provirus when it becomes activated, it may take its own sweet time. When it becomes activated, it will be transcribed into your unspliced, singly spliced. They'll be exported out. So that, and this will be translated first into a big protein. Okay, so that will be cleaved. Long polypeptide will be cleaved using protease. So at this point, you can use protease inhibitors. Again, we'll see that. And then these proteins and this will be used, will be assembling and budding out. Okay, so there are drugs at the level of fusion, binding, fusion, reverse transcription, integration, proteolytic protease. Okay, so the first to be discovered were your reverse transcriptase inhibitors. They are of two types. One are the nucleoside or nucleotide reverse transcriptase inhibitors, NRTI. Okay, so they are basically they compete. So we are putting in a synthetic nucleotide which is going to compete with your natural nucleotide to inhibit the reverse transcriptase competitively. So once it gets incorporated, the further polymerase activity will be stopped. Just like if you remember the DNA sequencing method of Sanger. So there was a deoxynucleotide which was being inserted. And once that is incorporated, the further replication will stop. So it is something of that sort. It is going to competitively inhibit the enzyme reverse transcriptase. The non-nucleoside analogs, these are NRTI. This was NRTI. So they non-competitively inhibit. So they were found later after this. The third class of drugs to be discovered was the protease inhibitor. So they were discovered nearly one after the other. They inhibit the protease enzyme. And then the more recent addition in the new millennium, we found about the fusion inhibitors, the chemokine receptor antagonists, the integrase inhibitors, and then there are other new classes always under discovery. So we can have drugs affecting the other stages of the life cycle. So I'll just discuss these. You don't need to remember anything, but for your understanding. So nucleoside reverse transcriptase inhibitors are nothing but nucleoside analogs. Example, Zidovudine. This was the first drug to be discovered. So this was a magic drug then. So all homosexuals had big unions fighting to get access to these drugs because there was definitely a rampant discrimination against the homosexuals. So that was also one problem why finding the cause of the disease was so difficult, because in the earlier days when they came with that Kaposi sarcoma and all, they were being neglected by even the doctors, and because people thought that okay, they are getting the punishment for whatever wrong they are doing. Okay, so people thought that it's okay, to hell with the homosexuals. But anyways, they found out the clustering of cases, and then they found out the final cause of the. Do watch that movie, which I mentioned. So Zidovudine is a competitive inhibitor of reverse transcriptase. Gets incorporated into the DNA of the host cell. So that will happen during. Okay, so fine. Host cell or virus cell? Okay, I'll have to check that. But anyways, you understand that it's a competitive inhibitor. At the same time, okay, so but it can also get incorporated into the DNA of our host cells, because we also use DNA polymerase activity. So that is responsible for its side effects. So even the RBC precursors or other rapidly dividing cells of us individuals, of humans, are sensitive to azidothymidine. So there will be side effects like anemia. Okay, so this is like what we discussed for cancer chemotherapy, that kills cancer cells, but it also affects other rapidly dividing cells. So this one also, it stops viral replication, but it can cause anemia and other side effects. Non-nucleoside reverse transcriptase inhibitors, or NNRTIs. So these are, example is nevirapine. So there are other things ending in pin. Okay, we will have. Okay, I've forgotten the names, but you can go and check. So nevirapine, I think lamivudine, stavudine, so those are also non-nucleoside reverse transcriptase inhibitors. So they inhibit reverse transcriptase non-competitively, but so because the mechanism of action is different, they are not going to have these side effects. The only example, only advantage of them, the main advantage is that they are not going to affect our RBC precursors and other rapidly dividing cells. Protease inhibitors, they target the HIV1 protease. Without protease, the peptides required for making your mature virions are not available. So all the drugs ending in vir, so sakinavir, ritonavir, fosamarinavir, lopinavir, all those are protease inhibitors. What is highly active antiretroviral therapy? So other drugs we are not discussing. Other classes I have just told you in brief. Okay, binding inhibitors, chemokine receptor antagonists, fusion inhibitors, integrase inhibitors. So all those things are also there. You will learn about them in pharmacology and in microbiology and all. So highly active antiretroviral therapy, HAART. So this is similar in principle to your ATT or the anti-tuberculosis treatment or the MDT, multi-drug therapy used in leprosy. How is it similar? I'm just telling you. So it combines the use of 3 or more HIV drugs from different classes. So similar is the case with your anti-tuberculosis treatment. It also combines 3 and more drugs from different classes. Why are we doing this salad? Okay, why are we making this fruit salad of different fruits? Why are we making this fusion blended malt or blended cocktail or mocktail or whatever? Why? Because viruses rapidly produce mutants which are drug resistant. Like I told you before, that even the influenza viruses, the common rhinoviruses causing our cold, cough, so we don't really make drugs against them because it is so difficult to target them. They keep on changing, they keep on shifting their genome. Okay, so they are rapidly producing mutants which are drug resistant. A combination strategy, if you don't give combination, what was found that initially patients who were getting Zidovudine or azidothymidine, they started responding very well, okay, but within 4, 5, 6 years, many of the patients reverted. Their CD4 cell count started falling. So you are going to progress, you're going to monitor the disease. You remember that graph by 2 things. Okay, you ask the patient to follow up every 6 months. You give them the drug, they come every month to take the drug, but you don't do the blood test every month. But after 6 months, you do the CD4 counts. You see how much it is. Nowadays, we also do the viral load. So what you will find is that if the patient is good, responding to treatment, the CD4 counts will be high, the viral counts will be low and stable. But if the patient is not responding or is worsening, what will happen? The CD4 counts will start falling, viral load will start rising. So in these patients, it was found that the viral load started rising, CD4 started falling, they started having opportunistic infections. So it was then felt that we need to attack the virus with 2 drugs, gradually 3 drugs. So then that is known as highly active antiretroviral therapy. So combination strategy overcomes the ability of the virus to this mutating ability by acting on multiple targets at the same time. Same principle is used in multi-drug therapies in tuberculosis, leprosy. So basically, these are all intracellular pathogens. So probably they act that way that we have to, in order to kill them, we have to focus on multiple targets simultaneously. I told the tuberculosis stays inside the macrophage, forms that cigar bundles and all. However, now coming to the other part about how it can't eradicate. So HAART can only stop the viral replication. That means the active provirus, which is undergoing transcription and producing new mature virus particles. Okay. Or if the new virus particle has entered the cell and is trying to integrate into the genome. So it will only stop the new cycle that is happening. Latently infected cells, where the provirus is silent, dormant, just getting replicated whenever that cell divides, T cells or macrophages, whichever, they are safe havens. They are safe havens, just like your Swiss banks. We say that Switzerland and countries like Camway Islands, which islands? I think Camway, I forgot. So they are safe havens for black money. That means black money gone there cannot be checked. You cannot. There is no account of them. You can't access them. So here, these are safe havens for HIV. These latently infected T cells and macrophages. They are safe havens because neither your immune system nor your drug can access them. So they are reservoir and they can produce infectious virus particles whenever they get activated. Also, the immune system may not sufficiently recover to clear the virus whenever it starts replicating. So whenever it starts replicating, the immune system again will be, victim to it. So it is not really going to help eradicate. So you can just remember that eradication so far has not been achieved. Treatment monitoring, like I told, is done using CD4 cell counts. Also, periodic viral load estimation by RT-PCR can be done. So stage 1, more than generally, this is the staging of HIV. Stage 1, the cell counts will be more than 500. So normal, like the window period, for example. So it will be more than 500 per microliter. Like I said, it is generally generally around 1000 per microliter. T cell percentage among the total T cell, the CD4 percentage will be more than 30. So normally, it is 2/3, 66%. Only the remaining are CD8, right? And there will be no AIDS defining condition. So all that the big list that I showed you of opportunistic infections and malignancies are known as AIDS defining conditions. So they won't be there. Stage 2, the CD4 cell counts will fall below 500. Okay. Earlier we used to start therapy only at this level. Okay, that was done around 2 years back. Until 2 years back, it was that. But now the rule has been changed to include everyone. So now anyone diagnosed newly positive, they will be started on HAART, ART. They will be started on anti-retroviral therapy. So stage 2 is 200 to 500. So CD, and still no AIDS defining condition. Stage 3 or AIDS is the terminal stage where CD4 counts are less than 200 and there are AIDS defining conditions present. So but now coming to the overall outlook for PLHA. What are PLHA? I didn't mention. So PLHA, on that global map showing distribution of HIV, I had mentioned the PLHA. That means people living with HIV and AIDS. Okay, so anyone who is HIV positive and on treatment is known as a person living with HIV and AIDS. So HAART lowers the plasma viral loads to undetectable levels almost. So if the person is responding well, you will not find RT-PCR test will show negative values. That doesn't mean that there is no virus. It only means there is no active provirus. Provirus can be latently it is generally still present. It improves the health of HIV patient to the point that they can function at a normal level. So nowadays it is just like any other chronic illness like diabetes, hypertension, which requires long-term treatment and which requires regular monitoring. You should just look at HIV that way. So if someone is HIV positive, one should not have a bleak approach, because nowadays the drugs are available and a lot of research is happening, even though eradication is far from, we haven't achieved eradication so far, but the lifespan can be prolonged to a significant degree so that the quality of life is not affected much. So in summary, immunodeficiency results from failure of the components of immune system. Primary immunodeficiencies are due to genetic defects present at birth. That means you never had those weapons. So they may be classified based on which cell types are involved, whether the lymphatic or the adaptive immune cells or the myeloid, that is the innate system cells. SCID, severe combined immunodeficiency, refers to a lack of functional T cells that also manifests as B cell impairment because the T cells won't help. No T cell help is available. So it profoundly affects both limbs of adaptive immunity, and the person is susceptible to a broad range of intracellular pathogens, right from the early infancy. B cell, selective B cell only. Now, immunodeficiency diseases affecting only the B cells are associated with susceptibility to bacterial infection. So I said antibodies are important as opsonins to target capsulated bacteria. So, and the defects could be single isotype defects like selective IgA deficiency, SIGA, or they can be total disruptions of humoral immunity like X-linked A gamma globulinemia or even X-linked hyper IgM syndrome. So that also a lot of humoral problems are there. Myeloid immunodeficiency, that they are going to affect your myeloid granulocytes or monocytes. So that means impaired phagocytosis. So we saw two examples: chronic granulomatous disease, where phagocytosis, the killing was problem, and leukocyte adhesion deficiency, where the migration to the inflammatory site was a problem. So they will again have bacterial infections, even fungal infections. Secondary immunodeficiency is due to drugs, infection, malnutrition. The most well-known form is AIDS. HIV-1 spreads through contact with infected body fluids, uses CD4 as the receptor and the chemokine receptor as the coreceptor, and fuses with the host cell. Gradual and severe impairment of immune system especially depletion of CD4 cells in the gut, can result in death from opportunistic infection. Treatment of HIV with antiretroviral drugs is done by antiretroviral drugs that target specific steps of the viral life cycle, and it is done in combination, also known as HAART, HAART. So thank you so much for bearing with me in this long lecture, and do revise and do complete your assignments. Okay. Oh, okay. This is again the same classification, primary and secondary. You can just go through it. Thank you.